Delta College.
It's the leading cause of liver cancer. And of the 4 million Americans who have it, 3 million don't even know.
Unlike many other types of infections, hepatitis C is not necessarily symptomatic. It can lie dormant for many years.
It's a silent epidemic that now kills more Americans than HIV, and most of them are baby boomers.
From a patient perspective, I think it's a very good thing if we actually screened all of the baby boomers for their hepatitis C status.
But there's some good news, too.
What I tell my patients now, it's a really good time to have hepatitis C.
New drug therapies have a cure rate approaching 80%.
There are probably 25 to 30 new drugs which are being studied, and all of which tend to target the virus more directly.
Also inside E Street, the pharmacy on a chip.
I don't know how long it'll take before a patient will have an implantable drug delivery system, but it'll happen.
Inside E Street is made possible by
Auto and home insurance from The Hartford. More than 200 years of helping to protect what's most important. For information about our program for drivers 50 and over, including how to find an agent, visit hartfordautoinsurance.com.
From the heart of the nation's capital and around the country, you're Inside E Street with Mark McCarthy.
An estimated 3 to 4 million Americans are infected with the liver disease hepatitis C. Most of them are boomers, and many of them don't know they're infected. That's because HCV, as it's known, can lie dormant in the body for decades without symptoms. So, many boomers who picked up the virus when they were young are only just now finding out about it. The good news is that powerful new drugs can cure HCV, and that's led to the controversial suggestion that all boomers be screened for the virus. We'll have more on that shortly. But first, let's go back in time and trace the origins of this silent epidemic. It was the late 60s and early 70s, and for many, the age of free love, getting high, and going to war.
I was wounded several times. I was there in 1968 and 1969. So there was a lot of blood and exchange that went on.
Antonio Gonzalez, now 63, got out of Vietnam happy to be alive. Yet the war left a permanent mark on him, something he didn't discover for more than 30 years.
I learned in 2001, one evening after supper, I began throwing up profusely. And I wound up in the hospital. And that's where the doctors told me that I have hepatitis C.
He was somebody who had to deal with the complications of cirrhosis and problems from that the first time that he was dealing with the disease.
Dr. Alexander Monto directs the liver clinic at the VA Medical Center in San Francisco.
Off your meds, on as low a dose of your meds as possible. We take care of a lot of patients with hepatitis C. We have about 165,000 within the VA system who are documented to have chronic infection and are in care at this point. They do tend to be Vietnam-era veterans more often. We also see that they're folks who've had other risk factors for liver disease over the years.
Primary risk factors for hepatitis C include IV drug use, tattoos, and blood transfusions prior to 1992. That's when the blood supply first began to be screened for HCV.
The virus itself was only discovered in 1989, so we had no way to know prior to that who in fact had the virus in their system. It became very common in the United States, particularly in the 70s, in anybody who had ever used needle drugs, as well as the fact that the pool for blood transfusions and clotting factors in the United States became more contaminated in the 70s.
That timing puts HCV squarely in the baby boom generation, and millions of boomers like Antonio Gonzalez have no idea they're infected.
Unlike many other types of infections, hepatitis C is not necessarily symptomatic. It can lie dormant for many years. It can cause, even as it causes damage to the liver, it can be asymptomatic for quite a long time.
Jeremy Goldhaber-Fiebert is a professor at the Stanford University School of Medicine. He notes that many people believe incorrectly that HCV cannot be cured.
There is a standard of care treatment that had been available up until very recently that involved 2 drugs. They're expensive, the treatment course is long, they have significant side effects and toxicities, and they are not effective for some percentage of people who take them. There are new drugs that are added to make a triple therapy, 2 different potential options. Those are even more expensive.
The 2 drugs in the standard treatment are interferon, which boosts the immune system, and ribavirin, which attacks the virus. The new drugs approved by the FDA in 2011 are protease inhibitors. They inhibit the ability of the virus to multiply inside the human body. When one of the new protease inhibitors, either Incivek or Victrellis, is added to the 2-drug standard treatment, it creates a powerful triple cocktail that's showing a cure rate approaching 80%. But that success comes at a steep cost, beginning with side effects.
We don't give these drugs to patients unless they know what they're getting into and that they clearly need them.
Side effects of the new triple therapy can include nausea, vomiting, diarrhea, acute skin rash, depression, and paranoia. But it's often the price tag that stops some people in their tracks.
Both standard therapy and the new triple cocktails are quite expensive. Because therapies aren't all the same length, cost varies. In many cases, the cost could be as much as $60,000 for treatment with triple therapy over the entire course for the patient.
That seems like an enormous amount of money, and it is. But when you think about the costs of treating hepatitis C later in the disease, when patients have progressed to cirrhosis or liver cancer, the cost of a transplant is something like $320,000 for the transplant itself, and then patients are generally on follow-up and medications that can cost $20,000 to $40,000 a year for the rest of their lives.
A recent Stanford University study shows that the cost of the new triple therapy is likely to be money well spent.
We found that depending upon the level of somebody's baseline liver damage, using the triple therapy appeared cost-effective compared to other types of health interventions that we use commonly use in the U.S. healthcare system.
Which brings us back to the question of who should get screened and treated for hepatitis C.
I would recommend to people my age and my friends to get a blood test and start looking into it. If I had been examined for Hep C 10 years prior, the manner in which I was attacked by my liver could have been lessened.
Antonio Gonzalez never had a chance to get any of the drug therapies. His disease was too far advanced when it was discovered, so he had to have a liver transplant. Still, he counts his blessings.
I live every day grateful and thankful, and I say my prayers for myself, my family, and the person who gave me the liver. It's a spiritual coming back and appreciating life, and I want to go on as long as I can.
As Gonzalez said, if he'd been screened earlier for HCV, he might have avoided the transplant. Joining us now from Atlanta is Dr. John Ward of the Centers for Disease Control. Dr. Ward heads the CDC's Viral Hepatitis Division, and he's the co-author of a recent study on hepatitis C in America. Dr. Ward, let's begin with your study and a finding I'm sure that many will find startling, that hepatitis C is killing more Americans than HIV. Were you surprised?
We weren't surprised, unfortunately, because the number of deaths related to hepatitis C have been increasing steadily in recent years, and indeed since 1999 the number of deaths from hepatitis C have increased over 50% to approximately 15,000 persons dying of HCV-associated diseases, including liver cirrhosis and liver cancer, which are both on the increase in the United States. Most of that increase is related to hepatitis C.
So with that in mind, because of what we do know about deaths and liver cancers, and because of these new treatments, one of the things that's going on is that you are looking at a new recommendation possibly for universal screening. So talk about what is being considered right now.
About 80% of persons living with hepatitis C were born between 1945 and 1965. And it represents, as was illustrated by your patient history, persons who were exposed in earlier life, either through injection practices or through healthcare contact through such as unscreened blood transfusions. And they've aged into a period of their lives where they are at increasing risk for illness and death from their hepatitis C, and that's what was illustrated by our analysis of mortality statistics here in the United States. So we're very concerned that we have this large population. 1 out of every 33 baby boomers are infected with hepatitis C. They're in a period of their life when they're getting sick from hepatitis C, and we have entered an era of more effective treatment for hepatitis C, and we at CDC believe it's our public health responsibility to look for ways to bring this at-risk population together with these opportunities to cure their HCV
Just so people
infection.
are clear about where we are, under the current guidelines, people are urged to get screened if you fall in a certain risk category. The change may be to go to an age model, meaning if you were born between these certain years, everybody ought to be screened. Is that what the discussion is?
That's correct.
Your study, got an awful lot of attention, and we're told that some clinicians are frankly interpreting your conclusions, even the suggestion of universal screening, meaning screen, boomer screen. Is that your view right now, that you would like to see this started even absent a formal recommendation from CDC?
Well, absolutely. I think it's very reasonable for patients in this age group and physicians caring for patients in this age group to begin to think of hepatitis C in this patient population and begin that conversation and begin to consider screening for this population.
Let's hear from Dr. Alexander Monto. He's a liver specialist with the Veterans Administration.
Certainly helpful in highlighting to members of the baby boom generation that it's important that they consider testing. But it would be expensive to test everybody, partly because once you get an antibody test, even if that's positive, you need to have a confirmatory viral load testing, and then you need to be seen by a liver specialist or somebody who's knowledgeable about hepatitis C to be considered for therapy. And then the therapies are quite expensive, and not everybody needs to undergo them, nor wants to undergo them. Birth cohort screening is controversial because most people in the birth cohort are going to be negative. Even in baby boom generation, the risk is 3%.
So Dr. Ward, let's deal with his last point first, where he says, most people are going to be negative, 3%. How would that compare, for example, to colon cancer screening or screening for high blood pressure?
When we look at the cost and the health benefits of HCV screening for persons born between 1945 and 1965, they're very comparable to the cost and benefits of screening for colon cancer or breast cancer or other prevention interventions such as a flu vaccine for older Americans. So we feel like it's a very reasonable approach to take. It is very important for us to receive that type of feedback about some of the concerns persons have about a birth cohort strategy, and then we work through those to develop a policy that's as widely acceptable as possible. The average age now in the United States of persons dying with hepatitis C is 57 years, decades younger than the average life expectancy in the United States. We can make a positive health impact by improving screening, improving persons' knowledge of their infection, helping those persons get into care, and then have a care managed by a knowledgeable clinician so that the decisions can be made as to who can benefit from treatment and who can benefit from just ongoing observation of their infection over time.
Yeah, we should point out that there are big side effects, with the treatment, and right now not everyone is cured. So do you say that the cure rate now, what, roughly 75%, even with the new triple cocktail? Is that the number you would use?
That is the number I would use. There are side effects. They have to be weighed against the benefits of treatment. But what we want to avoid are people having this silent infection for decades until they have symptoms of end-stage liver disease that represents a failure of their liver, high risk for liver cancer development, high risk of them having to have a liver transplant to remain alive. And all of that at a stage in their infection which is too late to benefit from these treatments. So early screening and early care leading to early treatment promotes maximum health benefits for persons living with hepatitis C.
Well, thank you so much for joining us, Dr. John Ward with the Centers for Disease Control. In a moment, we'll speak to a liver specialist who was cured after suffering for years with hepatitis C.
Visit us on Facebook at Inside E Street TV and follow us on Twitter at Inside E Street. Retweets are welcome.
We have more now on hepatitis C, a personal perspective from a man who gives a whole new meaning to physician, heal thyself. Joining us now from Seattle, Dr. Douglas Dietrich, a liver specialist and professor at the Mount Sinai School of Medicine in New York. Welcome, doctor.
Thanks for inviting me. It's great to be here.
Let's begin with your personal story. What a compelling story. 1977, you're a medical student and you have a needle stick and get hepatitis C. What were the first symptoms that you had?
Oh, I was pretty sick right away. I was really extremely fatigued, and then I woke up the next morning and my urine was the color of Coca-Cola. And then I looked in the mirror and my eyes were bright yellow. So I knew I was in trouble right away.
Bright yellow, sign of jaundice, right?
Sign of jaundice, right.
So even though you knew you were dealing with a high-risk patient when you got that needle stick, at the time there was nothing to be done, basically.
No, there actually wasn't. Although, frankly, I did go to the emergency room and they gave me a shot of gamma globulin. And frankly, in retrospect, that was 1977, gamma globulin frequently was infected with hepatitis C, so I could have gotten it from the gamma globulin.
So obviously for you, that was a life-changing event. The 1980s were a rough patch, right, as you tried to finish your medical training and became a physician. How bad did it get? There were a lot of lows during that period, weren't there?
Yeah, there sure were. And then whenever I went back to work, particularly tried to work as an intern, 120 hours a week, I'd be okay for 2 or 3 weeks, and then the fevers would return, I'd get jaundiced again, and my liver enzymes would go up, and I'd have to go back on, sort of easy duty, 40-hour a week, duty for a month until I recovered, and then try to go back to the wards to do my time, and then same thing would happen over and over for a couple of years.
So as you're suffering from this disease, you decide to start studying it, right? So how did you become a liver specialist?
Yeah, I was all ready to be an ophthalmologist. This just made me so angry that there was no information on this disease because they were calling it non-A, non-B hepatitis.
So let's talk about your research led you to, to know about, drugs that were coming in the pipeline. Why don't we get to the moment when you were cured? What do you remember when someone said to you, there is now hope for a cure and you're a good candidate?
Well, someone didn't really say that to me, because I was working in the field by then. I took the first treatment at the NIH I think in 1989, and then I went back and forth to the NIH for about 15 months, and then it actually failed after 15 months of the interferon treatment. At that point, there was no ribavirin available at that point. So then when ribavirin became available as the second drug, we added to the interferon, and I took the medicine daily for 18 months with the ribavirin. And it resulted in a cure.
Right. I mean, can I just stop you right there? I mean, the moment that you were able to use that word cured, after all the years that you suffered, what was that like?
Yeah, that was good. That was a good celebration, I have to say, because you know, there's not many diseases that we can cure like this. Not many viruses that we can cure. You know, we can't cure HIV, we can't cure hepatitis B, but we sure can cure hepatitis C, and we can cure a lot more people now.
Well, let's talk about where we are right now with this new triple cocktail, very promising. What's your message to people who have hepatitis C and about this triple cocktail?
Yeah, well, you know what I tell my patients now, it's a really good time to have hepatitis C. If you have to have it, now is the time, because we have 2 drugs that are on the market, 2 protease inhibitors, and the cure rate is now approaching 80%. For patients, the first time through, and the treatment is no longer for 48 weeks.
How long is it now?
Right. Well, if you're if you're responding really well to treatment, in about 60% of the time, you can stop at 24 weeks in 6 months.
Talk about the side effects. Do you still have patients who are resistant to undergo treatment because of the side effects, and because of your
sure.
personal experience? What do you say to them?
Yeah, you know, I don't just, you know, I haven't really gone public with it until this year because I thought it was a good time. I've never hidden the fact, or, you know, and I don't tell every patient, but you know, I play the card when I need it. You know, when somebody's sort of whining about taking the injections, you know, I say, come on, suck it up, you can do it. You know, I did it twice.
I do want to ask you, we talked with Dr. Ward a few moments ago from the Centers for Disease Control, and a policy change is under consideration, and the possible change is moving toward universal screening, basically for baby boomers. Do you support universal screening based on year of birth?
I absolutely do. Frankly, I go further than that. Personally, I would just think we should do universal screening. It's a very cheap test to do. It's a simple blood test. No reason not to get screened. It costs $8 to do the, you know, the blood test, and this is a disease that could kill you if you don't know about it.
So, doctor, just to sum up here, your message is get screened. You know, everyone should be screened. Starting at what age? What would you say?
Personally, I think you should just test everybody, because now's a good time to have it. We can treat it. We have 30 or 40 new drugs coming. If these 2 particular drugs we have now on the market don't work, there's lots of other drugs in the pipeline. So it's a wonderful time to have hepatitis C. We're going to be able to cure it, but we got to know that you have it before we can cure it.
Well, Dr. Dietrich, thanks so much for sharing your expertise and for sharing your personal story. Thanks so much.
Thank you.
In a moment, the day you've been waiting for is getting closer.
For more information on hepatitis C, go to InsideEstreet.org.
One more thing, it's being called a pharmacy on a chip, a microchip that is, an implantable drug delivery system that could revolutionize the way we take medicine. Imagine no more daily injections or worrying about taking your pills. Here's how the technology is designed to work. A chip implanted just under the skin below your waist will automatically release the right dose of medicine into your system at just the right time. An idea that first came to MIT's Robert Langer when he was watching a public TV documentary in the mid-1990s.
They were showing how microchips were made in the computer industry, and I thought to myself, this would be a great way to make a drug delivery system.
The first human trials took place at a Danish clinic outside Copenhagen. 7 women were implanted with the device.
The 7 patients that were selected for the trial were postmenopausal women between the ages of 65 and 70 years of age, healthy but had osteoporosis.
Robert Farah was the lead author of the study that showed how an osteoporosis drug normally taken by injection could be safely delivered through an implanted chip.
What you have is a microchip implant. It's very tiny, about the size of just a small part of your finger. Then you would implant it in the body. The wells are sealed, they're hermetically sealed, the drug can't come out. And then you can apply a small amount of voltage by remote control, and it actually will cause the cover of a particular well to open, and whenever you do that, the drug that's stored in that well can come right out into the body. When we're putting the drug in the microchip, it's all drug, it's pure drug. So you're concentrating it tremendously, so you can get away with much, much smaller volumes. I think what this initial trial tells us is that telemedicine's possible. I mean, now you can do remote control drug delivery. I believe someday you'll be able to do remote control sensing. Let's say somebody has a heart attack and the chip will deliver the drug in response to that, and so that would be a great thing.
The biggest benefit of the device may be compliance. For example, only 25% of osteoporosis patients who take a daily injection typically complete the regimen at the end of a year. Langer and Farah say the drug delivery microchip may be available in 4 years after more clinical tests. Next, inside E Street, faced with a terminal illness, when do you make the decision to let go and not use every available means to prolong life?
I'm going to miss my family, I'm going to miss my friends, my plants, my pets. But those are things that eventually everyone is going to have to leave.
Thanks for joining us. I'm Lark McCarthy. See you next time inside E Street.